Hello, welcome to TCTAP. My name is John Hodgson. I'm from Cleveland, Ohio in the United States, and it's a pleasure to be here with some very distinguished investigators, Dr. Akasaka, Dr. Maehara, and Dr. Regar. And we're going to be discussing about vulnerable plaques, and I will start out the discussion by showing a few slides with just some background studies to get us up to speed on some of the recent data. And then hopefully we'll have a very lively discussion with our experts here. So without further ado, let's go ahead and put up the slides, please. Great. So we're going to briefly go over some of the natural history studies of vulnerable plaque, including those listed here, and then talk a little bit about local treatment of vulnerable plaques and discuss whether we believe it will work or not. So here are a number of the natural history studies for vulnerable plaque. The Prospect study, of course, using VH-IVUS. There's Viva using VH-IVUS. Prediction also using VH-IVUS. The Atheroma-IVUS and the Atheroma Nears using both VH-IVUS and the Near spectroscopy, as well as some CT studies and also some studies just using physiology measures. And these have all shown similar results in terms of the IVUS studies or the IVUS-based studies, where thin cap fibroathromas or with the Nears, very high lipid core burdens and severe plaque burden inside the lesion are predictors of subsequent events. I think you're all familiar with this slide from Prospect, and it shows that if you see on the far left, the rate of major adverse cardiac events at 3.4 years, if you had a thin cap fibroathroma, was approximately 4 times that if you did not. And these thin cap fibroathromas were quite prevalent at about 50% of the patients that were studied. And then as you go across to the right on this graph, you can see the more other risk factors that you add, including plaque burden there in the third category, and a small minimal lumen area in the fifth category, starts becoming additive. And I think if you look specifically at the second to last column, where you have a large plaque burden and a thin cap fibroathroma, you've got an event rate over 3.5 years that's about 15%. And this is clearly much higher than that for those where these attributes were not present. And importantly, the prevalence of those types of lesions was about 11% in the patient population. So we can't get so restrictive that we identify only a couple of percent of plaques, and yet we obviously can't do anything if 50% of the plaques are involved. So we have about an 11% incidence in this Prospect trial. Interestingly, one of the sub-studies of Prospect looked at the non-fibroathromas and documented again that these patients are extremely stable if you have a non-fibroathroma in your alternative vessels, and the risk factor there again was quite a bit higher if you had a thin cap fibroathroma than if you just had fibrous plaque. The Vive study, looking again at non-culprit lesions with VH-IVUS. This was a 3-vessel study with 2-year follow-up. There were 13 events in the non-culprit lesions out of 1,096 lesions, which is about a 1.2% event rate, so a fairly low event rate over the 2 years of follow-up. But those lesions who had a plaque burden of at least 70%, as you can see here, had a much higher event rate than those lesions which did not. And those that had a VH-defined TICFA had a relative risk ratio of 7.5. So again, very high incidence of trouble if you have a high plaque burden or a thin cap fibroathroma. The prediction study was a study from Japan that looked at biplane angiography and intravascular ultrasound to create 3D modeling and calculate endothelial shear stress. And again, they were looking over a period of approximately 6 to 10 months at progression of plaque, and specifically those that required a subsequent intervention. And they found that if you had a very large plaque burden at the baseline study, that was a predictor of subsequent need for percutaneous intervention, as well as if you had a low endothelial shear stress. So again, that plaque burden comes up as one of the clear predictors of lesions that are going to progress and cause trouble in the future. If we look at Moe Nears, this was sort of a sub-study of the Vive trial, included about 203 patients, and they used near-infrared spectroscopy and merely divided the group into those whose lipid core burden was less than the median, those whose lipid core burden was greater than the median, so not an absolute value cutoff, but again showed that if you have a high lipid core burden, that your risk of events is considerably higher than if you don't. Another marker there of a vulnerable plaque. So I'd like to just open up for a second with a little bit of discussion about the lessons that these natural history studies have given us. And perhaps, Akiko, we could start with you. You've done a lot of work, obviously, on the VH-IVIS and also the Nears. What do you think these studies now are showing us?
I think the whole study is very consistent, meaning more plaque doing bad, and then more plaque also having more necrotic core, and by Nears, they have more lipidic plaque. So more plaque equal to more lipid. And then they are very consistent answer to predict the future event. And also importantly, we learn from the Prospect trial that small lumen is also bad, which we also learn from the FEM trial too. Meaning like that they're including all together small lumen area, big plaque that's equal to a lot of necrotic core, they are bad. That's, I think, all of the study is tell us very consistent answer.
And Evelyn, could I ask you to just comment on how common these types of plaques are? And if we're going to use this every day, obviously we can't use criteria that would include all patients and all plaques. We need to be able to find specific plaques that might benefit from special therapy. And so what do you feel is the best way to find those unique plaques, and how frequent are they in the patients that we treat?
So the problem is, of course, that we can only find these plaques if we bother to do invasive imaging. So there is no shortcut to that. We know today that we have very sensitive tools in identifying lipid and atheroma-rich plaque, necrotic core-rich plaques. We start to understand that this is of prognostic value for the individual patient, and we start also to understand what the potential impact of treating these lesions is. But we need to go to the effort to take a catheter down into the artery and image the artery.
Yeah, I agree with you. It's, as you know from a number of these trials, they tried to do 3-vessel imaging. It's pretty difficult to get investigators to do that, even in a study, let alone in routine clinical practice. So
I think there is good news coming out of the Atheroremo series. We have now looked at the data, at the 4 years follow-up data. You showed the publication with 1 year follow-up. I can tell you these data hold true up to 4-year follow-up. And this is really, really exciting, because what that means is that if we just image one artery, a non-stenosed arteries in patients presenting with coronary artery disease to our cath lab, we can get at least a risk marker, if you want, for the future risk of this patient. So this allows us, and interventional cardiologists now for the first time, to really do a specific personalized risk assessment for the patient. And I think that is exciting, and the interesting news is that you don't need to look at the complete coronary artery tree. The Atheroremo Nears data suggests that just imaging 40 millimeter of one artery might be enough to get this clinically relevant information.
Okay. Dr. Akasaka, let me ask you, I think what Dr. Regar is mentioning is that the concept of the vulnerable patient. So if you find that vulnerable patient, regardless of which artery you study, that would imply a treatment strategy that it's likely medication-based, not local-based. What is your feeling about the importance of finding specific plaques in specific regions of the artery that might require a local therapy versus this concept of just finding a vulnerable patient?
Yeah, to identify the vulnerable plaque itself, I think it might be very difficult at the moment because if we identify the vulnerable plaque, we can say the patient should be the vulnerable patient because we can identify the lots of vulnerable plaque in the other region. But it might be very difficult to predict when the plaque will have the problem. So at the moment, the identification of the vulnerable plaque is developed very much, and we can identify the vulnerable plaque in some degree. However, in my private opinion, it is still not enough to do the local therapy. If there are flow-limiting vulnerable plaque, everyone will agree to treat, but non-flow-limiting vulnerable plaque, we do not know the prognosis at the moment, and also difficult to predict when the plaque will have the event.
So, Dr. Maehara, it's clear that if you have these high-risk features, they do worse than if they don't have the high-risk features. The problem is the event rates are still quite low.
Yep.
They're quite low. So what are you aware of, or what do you think we can do in the future to try to better characterize those where the event rate might be, let's say, 30%, 40%, 50%, that could justify then trying to do something locally?
Yeah, I think probably imaging itself may not be enough. That's most probably important. We have to see the patient characteristic, including the everyday, the changing of the inflammation or lipid profile. And then, yeah, that's we need. And also, even though we say 3 factors is important, but usually they are located in the proximal portion. And then, if we consider the impact of that region causing the patient outcome, of course, proximal LAD is more important than very distal portion, or LAD is more important than circumflex. So we already know which region is important. So I think to consider the what's most impact for the patient at the region level, we already know if that's kind of vulnerable plaque located in the very proximal LAD left domain, that's probably the answer which we start doing something from there.
So as we move into doing something,
Yeah.
Let's go back to the slides for a second, and let me show you just a couple of more. So if you could bring those slides back up again, please. So we'll move into this local treatment group here. So this is the STABLE trial, a trial from here in Korea that put people after an intervention on rosuvastatin. They all got rosuvastatin in either a high or a low dose, and they all had virtual histology IVUS, 312 patients. And what you're seeing here is the amount of necrotic core change over a 1-year follow-up. And you can see that the changes were relatively small. But I think the more important features on the far right there, this thin cap fibroathromas actually reduced from 55% of the baseline lesions. And in those same locations studied a year later, the thin cap fibroathromas had reduced to only 20%. So a number of those fibroathromas changed from thin cap into less dangerous thick cap, or in some cases, just pathologic animal thickening. So there is clearly an effect of statins on removing some of the lipid core and changing plaques from more vulnerable into less vulnerable, and this is just one of the latest of many trials that have shown this. The Erosion Trial, a little bit different. This is an OCT study from China that looked at the patients with acute infarctions and OCT. So they originally had the vessels open, did some thrombectomy, and then did OCT. And if the OCT showed an erosion, they elected to leave those patients alone. So they did not get a stent. And this study looked at what happened to those patients over 1 month with a repeat study. And these graphs just show reduction in thrombus identified by OCT. But it raises the interesting observation that not all plaques need necessarily to have a stent. And in this case, if the underlying event was due to a plaque erosion, as opposed to, say, a plaque rupture or a calcium nodule that had ruptured, that the patients did quite well without a stent, and they really had no events in this group. Now, Prospect 2 is actually looking at these features of high-risk vulnerable plaques, and if they have those features, randomizing them to an absorbed BVS or guideline-directed medical therapy with clinical follow-up for a long time. And so this is one of the first trials to actually promote putting a stent on top of what is identified by VHIVIS to be a vulnerable plaque. And I'm sure Akiko's been analyzing some of these, and maybe you can comment a little bit on that. The PREVENT trial doing somewhat similar. First of all, the lesions had to be non-flow limiting by FFR, so the FFR greater than 0.8, and at least 2 of these characteristics that you see there, a TICFA by IVUS or OCT, a small lumen area of large plaque burden, or a high lipid core burden index. And so these are all things that we've already seen, and now people are using those as a marker of a vulnerable plaque and then randomizing to a BVS in this trial again versus optimal medical therapy, and with a 2-year follow-up. So there are some early trials now looking at stenting, in this case, both cases with biodegradable stents. And of course, there's a number of trials now showing that we can modify plaque composition as well as plaque volume using high-dose statins. So let's go back to the panel for a second. Dr. Regar, how do you weigh in on this? Are you going to be a local stent fan, or are you going to be a systemic therapy kind of fan?
Probably both, because it will depend on the location of the lesion, and it will also depend on how good our stents are and how good we will be able to implant them, because we know that lipid-rich lesions are prone to higher periprocedural myocardial infarction rate, and this is linked to worse outcome in our patients. So we need to also make sure that when we decide to treat a lesion, especially non-flow limiting lesions, that we can also control for periprocedural events that might be associated with this treatment, because what we know is that when we implant a stent, especially if we do high pressure balloon dilatation afterwards, the struts are prone to cut into the plaque and to disrupt the necrotic core. So this is something that we probably will need to balance and to understand the benefits of this. And the other thing that we see from the BVS series of trials is that if we implant a scaffold and if we do a good job, we might solve a local problem, but we also need to take care. We need to take care about the risk profile of our patients, because if we don't do this properly, what we will see is, and we have shown that in cohort A series, we will see progression of the disease, progression of the lesion. You might call it neoatherosclerosis in the regions where the scaffold has been implanted, with again the risk of accumulation of necrotic core and again the risk of plaque rupture. So just believing that implanting a stent or scaffold and leaving the patient alone will not be enough. But the good news for me is that we are able to now identify these patients at increased risk, and it might help doctors to really focus all their efforts in convincing patients to stay on drugs and reducing their risk profiles. And it's also for the patient, I think, a much greater motivation if he knows that he's not a statistical number, but that is his individual risk.
Great. And Dr. Maehara, the problem, I think, as Evelyn beautifully described here, is a risk ratio balance. So we've got stents which might have a 3, 4, 5% complication rate at a year if you include all the, peri-procedural, everything. And you've got a vulnerable lesion which has a 3% risk over a couple of years. So I think you were onto something when you said, we need to take into account other factors. So I think if the patient is already multiple risk factors, if the lesion is proximal LAD or other things, maybe that's what tips you over to trying to do it. But what's your view after looking at a number of these studies that are coming through? Do you think this stenting of these lesions is making sense?
Personally speaking, I think it makes sense, or I would say feasible, at least by observation of the prospective trial. But what I saw as a big issue was people hesitate to randomize because people are not sure this is 65% plaque burden, maybe 70, maybe not. And then they are not sure based on the plaque burden to randomize. So I really thought like local treatment therapy is feasible. However, if we would do this as general therapy, generalize, it's a very difficult, meaning I'm okay to say this is 70%, but many people in the cath lab, they are not okay to say to be confident. So if we start doing that kind of therapy, we have one more step to have to solve. Has to be the measurement is easy and also reproducible and quick, and then everybody can understand easily. Without having those technology, even we have the good concept and then we can prove this is feasible, it's not very easy to move forward. That's another aspect, yes.
So we've got to go back to teaching people
Yeah.
how to read IVUS again.
IVUS is, just a little bit difficult, but I think we have to
years,
make the easy
Yeah.
picture to make it easy to everybody.
So-
yeah.
Dr. Akasaka, let me just propose something different. We can use these same technologies to improve how we treat the flow-limiting significant lesions we have now. For example, there are often cases where we have geographic miss. We have vulnerable plaques next to where we land a stent, or we've got high lipid burden outside of a region that's adjacent to where the lesion is. What do you think about using this data now to optimize the stent that we are putting in for the lesion that's present?
It's a very important question, I think. We are now focusing on the wall itself, right, by imaging. But the vulnerability is not based on the anatomy, but also we have to think about the physiology. At the moment, we do not know the physiology in detail. Just we can get an FFR or CFR or other index, but if we can get another information about the wall shear stress, we can get much more information. For example, Dr. Koo in Korea, he tried to do such kind of study. He named Emerald study. It's a retrospective study, but in addition to the anatomical information by CT, he tried to measure the pressure gradient by FFR CT and also the shear stress, and the prediction rate should be very high compared with the previous data. So the vulnerability is not based on the anatomy, so we need additional information. If we could get, we will predict much more, and then we can randomize much more safely, and we can expect
So
a good result.
What I hear you saying is that we need more specific techniques to really identify those very high-risk plaques.
Yes.
So Dr. Regar, can you comment on what I mentioned a second ago about using these vulnerable indices to guide our current stent implantation? We know we have a lesion, yet we often just visually guess where to put the stent. Using these techniques, do you think we can do a better job of that original implant?
Sure, we can. I mean, we know if we do invasive imaging, we can identify patients that are at high risk for events. We know that if you use invasive imaging, we can optimize our procedures in such that, for instance, we make sure that our stent length is adequate so that we cover adjacent necrotic core proximally and distal to the stent. We can make sure that we expand our stent adequately. The piece of the puzzle that is missing is the prediction on which so-called vulnerable plaque or plaque with features of that will rupture in what time frame. This is exactly what is missing. This is what Professor Akasaka was alluding to. And here probably we will need more functional information. You can think about physiologic measurements, but you can also think about new advanced technologies which can tell you about the functional state. For instance, if you think about polarization sensitive OCT imaging, it can show you the amount of collagen in the plaque, the degree of organization of the collagen. That could be a risk marker together with shear stress or others. So I think we are moving in the right direction, and really in my mind the last piece of the puzzle that we need is the prediction of an individual plaque to rupture. And this is what we have not yet achieved, but we have gone a long way, and I think we are making good progress there.
Great. So I have said for the last 20 years that the most important thing that I do in the cath lab is to put a patient on statins, because that has an impact on their ultimate situation. And I think now with the PCSK9 inhibitors, we can get LDL levels very low, and the early trials are already showing plaque regression and distant augmentation of what we already know. Let me be the devil's advocate. Wouldn't it be better you identify a vulnerable patient by any means to justify putting them on an agent like that, get their LDL really low and stabilize all their plaques, rather than try to hunt for the individual plaque that might rupture? Dr. Maehara, what do you think?
I agree.
You agree? Okay. Dr. Akasaka? Yes, okay. So we've got just a couple of minutes. In 30 seconds or less, Dr. Regar, will you sum up what you think the most important thing that the average practitioner needs to know about vulnerable plaque today?
I think the most important is that in patients that are suffering from coronary artery disease, we are now able to really identify those who are at a massively increased risk of developing coronary events out to the next 4 years. So I think these are the patients where we can focus our intensified effort in risk factor reduction.
Okay. Dr. Maehara, same question.
I have a little bit different. We didn't talk too much erosion today, but I think we missing like 30% of the cases which causing the thrombotic event not coming from the plaque rupture. Those are more likely thick cap and little repeat. So we are missing for those to identify. That's, I think, even interventionalists should keep in mind, because they are more likely easy to stent with, because plaque is not so much necrotic core and less thrombotic. That's actually 30% of the cohort, which we should keep.
And Dr. Akasaka, the most important thing for people to remember now.
Right. The interventionist try to use an invasive imaging, but at the moment we have a non-invasive method, for example, CT and CTFF or other methodology. So we also pay attention to the other methodology development to identify the real vulnerable
So looking
plaque.
at the non-invasive.
That's right.
Great. Well, thank you very much. We're out of time. I appreciate all of you coming and sharing your expertise with us. And obviously a lot more to come in the field of vulnerable plaque. Thank you.